My name's Janet Cogswell. The first thing I have to do is apologize because the title is incorrect. It's ASCO ONS Chemotherapy Administration Standards. So now I don't have to identify that I am a nurse. I identify as a nurse, although I am a member of ASCO as well. I have no financial disclosures, and there will be no discussion of off-label use of any drug or investigational use of any medication. I do want to go over a bit of history of the standards and then to talk a bit about a study that was done 2 years after the standards were initially produced, so that you have some idea and some concept of what you're going to face if you try to implement the standards in your facilities. In 2008, ASCO and ONS formed a work group, and they wanted to come up with some standards for the safe administration of chemotherapy. It was an outpatient focus. There were 31 standards that came about. And how did the standards came about? They had a group of stakeholders. They had physicians, nurses, pharmacists, advanced practice nurses, members from the American Cancer Society, the NCI, and they all came together and decided that these are the standards that we should meet if we want to be administering chemotherapy safely in an outpatient setting. In 2012, they were updated and basically the same standards were kept, and they were expanded into the inpatient chemotherapy units. At that time, in 2012, it was acknowledged that there needed to be additional information included about oral chemotherapy, but it was felt it was beyond the scope of that work group. And a third work group was convened at the end of 2012 just to handle the unique administration peculiarities of oral chemo. In the very original 2008 standards, oral chemotherapy is included, but the oral chemotherapy that was addressed in 2008 were the overall global chemotherapy issues. And they wanted to remind everybody that oral chemotherapy is chemotherapy and falls under the same safety precautions as intravenous chemotherapy. The 2013 standards were created to reflect the fact that oral chemotherapy has unique administration problems. Okay, so this was initially a collaborative, multidisciplinary process. The steering group identified key articles, relevant literature, and created a reference list that was sent to 40 diverse multidisciplinary stakeholders: social workers, administrators, patient advocates, all the cancer societies, the ACS, the NCCN, the Joint Commission, the Institute for Safe Medicine, and they created 64 standards. And then they were presented to the full group of stakeholders, and they were edited down to 35 standards. The standards were disseminated to members of ASCO, ONS, and then were also publicized through the American Cancer Society to patient advocates. There were 312 individual responses and 10 responses that were made directly to ASCO and ONS and not through this WebMonkey survey. Draft standards receiving less than 90% yes votes were reviewed, clarified, and modified. 4 standards were eliminated. This resulted in 2009 31 standards that were published. In 2011, the same format was followed. The only difference is that because as the standards were being implemented, they reviewed comments received from members of ASCO, ONS, and QOPI about questions and clarifications required for the different standards. There were 87 individual responses of individuals calling their organizations and asking for clarification of the standards. And these standards were published in 2012. The reason that everyone has seen this information, the reason that oral chemotherapy has come under scrutiny is because that they know that from an NCCN report that 1.5% of insurance claims are for chemotherapy. And in 2010, 16% of these claims were for oral agents. And in the drug development projections of 2010, 25 to 40% of the new agents are predicted to be oral agents. And it really has unique challenges. When we go in further to discuss what some of the changes were, I'm not going to go over each standard and tell you exactly what wording was changed. It's very easy to find the information. You can Google ASCO ONS Chemotherapy Administration Guidelines. And right up here on the corner, I made some copies. There are a limited number of copies because I didn't know how many people would be here, and I didn't use any government funding. I paid for it. So, but for anybody who feels they would like a copy immediately to read on the way home, there's a stack right here in the corner down this side of the hall. Probably the biggest shift is the shift of responsibility to non-oncology professionals. And when we say non-oncology professionals, we're talking about patients. This is shared decision-making above and beyond what we've ever discussed before. This is home care agencies, because we send patients home on oral chemotherapy, and we expect that the visiting nurse is going to be doing the monitoring and assessment. And then also, as we have survivors and we have oral chemotherapy agents, they are going to be administered on non-oncology units. Some of the other problems with oral chemotherapy is drug and food interaction, and of course, what happens if a patient misses a dose? Not if they just forget to take the dose, but what if they vomit the dose? There are also fewer opportunities for education. Most of the education was received. When you had the patient in the chemo chair for 4 hours, you had to talk about something, right? So there was a lot of patient education that went on during that time. But now, what do you have? A lot of patients on oral chemotherapy have a 5-minute phone call, if it's 5 minutes. They get a phone call, do you got your drug, are you taking it, any questions? Okay, and I'm charting. So you also have less interaction, and because there's many alternative sites of interaction. What alternative sites of interaction mean is we've given up, for nurses who are control freaks, we have given up control of a lot. We don't administer the drug. We're giving the treatment plan to other nurses, patients, and we're also not even always using our own pharmacies. So we're used to using one pharmacy. We're used to dispensing the medications ourselves. Well, now we have specialty pharmacies. And so the medication is being ordered by us, transmitted through our pharmacy to a specialty pharmacy. The specialty pharmacy contacts the patient directly and ships the drug to them. Handoff communication of treatment plan is difficult enough. We all know the problems we face with the end of treatment summary. Well, now we have the problem of an ongoing treatment summary. So it cannot be that patients are on medications for months and months and months. And you know what? That's a really good thing. We have patients on Gleevec or imatinib for years now. Well, when did they start? How long are they going to stay on? What is the plan? What's the end date and what's the evaluation point? Of course, everyone has talked about this, the cost is high, and that the treatment dates are very difficult for patients to keep track of. Continuous, intermittent, cyclical, do we stop and start, dose reduce, dose increase. So in 2013, the steering committees met to incorporate these unique challenges into their standards. They did the exact same thing. It was a steering group, 38 participants met, and the results were posted for public comment. There were 2,007 responses this time. I think this is interesting because the first set of comments received 300. The second update, there were approximately 90 comments, but in 2013, with the inclusion of oral chemotherapy, there were 200 responses. Again, 205 through the web survey, 2 direct communications. It is also interesting that the breakdown of participants in the public comments, they were overwhelmingly nurses. So whatever the standards are, while they are the ASCO ONS standards, a lot of the driving force behind these standards were nurses. The question was asked, should this standard be included in the final set? And then standards that received no, or standards that did not receive at least 90% yes, were reviewed for clarification, editing, or elimination. The reason I spend so much time talking about that is because the way this was set up, no one asked that second question, is this a good standard? No one followed it up with, do you think you can implement it? Or are the systems already in place in your institution to allow you to implement this? So, in our updates, so what are we going to expect in 2013? What are the major issues? Patient adherence. Is the patient going to be able to take the medication the way it was meant to take? Now, adherence has several breakdowns. It's not only does the patient want to take the medication, and there was a lot of discussion over a new concept called patient engagement, because we do know that when patients are faced with a provider, they want to go along with the provider. They want to be a good patient, and they want to say, you know what, give me that prescription and I'm going to take it. But just as when they finally start to look at the data for how many prescriptions were actually filled when physicians were giving women hormonal therapy for hot flashes, it turns out approximately 40% of those prescriptions were never filled. The women didn't want to upset anything, so they would take the prescription, they would just never fill it. So that's the concept of patient engagement. It's more than I'm just listening and I'm not going to argue, but are they really invested? Patient engagement was dropped as a concept in the 2013 standards because they felt that they could not be measured. There were not enough tools, or the ability did not exist to be able to see or to be able to record engagement as a concept. The other things, barriers. There are barriers to oral chemotherapy, cost of course, but cost is not the only barrier. What about the tried and true things? Can they open the bottle? Can they keep track of the cycles? Are they taking so many medications that there's actually, we had a patient that decided to come off the chemotherapy, oral chemotherapy, because there was not a time on her schedule where she had an empty stomach. She was taking so many different medications and just decided the benefit of an additional medication was not enough. Can they remember what the treatment plan is? Can they get to the pharmacy one of our problems is we have patients get the chemotherapy is mailed to their house. And because it's an oral chemotherapy and because it's extremely expensive, they have to sign for it. But they work. So who's at home to sign for the chemotherapy? These are all the different barriers to adherence that were discovered and have been discovered as oral chemotherapy is becoming more popular. And these are things that should be discussed ahead of time. So those are the overall global concepts of what you're going to see in the updates. Safe handling was included. That was just an oversight. Oral chemotherapy should be handled appropriately with the same concerns as IV chemotherapy. And the requirements for basic life support were added only if it's in the healthcare setting. Fertility and pregnancy were added as new standards. Now, why? Because think, when you want to talk patient involvement and patient engagement into your treatment plan, it used to be that if you had a woman who could potentially be pregnant, before you gave her IV chemotherapy, what did you do? You ran a pregnancy test, right? It's a 15-minute test, and you knew whether or not your patient was pregnant. What if you're sending your patient home on continuous chemotherapy? When do you take the pregnancy test? How often do you take the pregnancy test? Is a pregnancy test required? Those are discussions that have to be made at the very start with the patient, and they need to be documented. Because if you do have a patient that becomes pregnant while on oral chemotherapy, then you have liability issues as well. So you want to make sure that that discussion, and it should not be a one-time discussion, because you're talking to patients over time. Things change in patients' lives, right? So right now, the patient says, I have no plans to become pregnant. Well, you know what? I'm not married right now. 3 years later down the line, you know what? Oh, things have changed in my life, and maybe I'd like to have a baby now because I've been cancer-free for 3 years. And remember, some of the early discontinuation studies on imatinib happened when women became accidentally pregnant while they were taking imatinib, and the decision was made to stop the drug. So this needs to be an ongoing discussion with the patient, and it has to be a discussion with the patient because you want to make sure that the patient is open with you. You don't want to just say to the patient, oh my goodness, you know what, we don't know the effect of this oral agent on your unborn child. So we recommend that you don't get pregnant. You know the whole speech on the lenalidomide and thalidomide speech. What you want to say is, what do you think about this? Because you know what, there are patients who are going to tell you, well, I hear what you're saying, but I'm telling you that for my own personal beliefs, I am not going to use contraception, and there is a good chance I may become pregnant while taking your drug. So this needs to be an ongoing conversation, and that person needs to be confident enough to be able to talk to you about that, and you're not going to push back. Then we talked about standard number 21 is new, and in it is included the difficulties in obtaining, paying, and adhering to the chemotherapy. Now, how many people here in the VA have patients that they've never been seen in the system before, but they come to you with a prescription for a new oral agent because it's extremely expensive, and they can no longer afford it, right? That's like 75% of our work now in the outpatient clinic. This gets to be very difficult because who's in charge? Who's watching the patient? Right, we want to say we're in charge, but it's the person, as I try to explain to the patient, the person who writes the script is ultimately responsible for that script. But we need to take a step back and say that the person who is actually in charge is the patient, and we want to engage the patient so that they understand what our role is, what the role of their private physician is, and what their role is. Drug storage was addressed in Standard 8, and these are new, but what they did is they brought small private freestanding facilities into the same Joint Commission standards most people who work in institutions are familiar with: tall man lettering, look-alike, sound-alike drugs, etc. Now, documentation of the changes in oral chemotherapy were required in Standard 9. And why does this come about? How often when you do med reconciliation do you look at the med list and it says, oh, okay, so you're taking lisinopril? Oh no, I called my doctor when I had developed that cough and he told me to stop it. But it's not charted anyplace. It was not taken off the med list in CPRS. So according to the medication reconciliation, you're still taking it. And this is the importance of medication reconciliation now. You really have to go over all those meds, but also the standard says is that chemotherapy is not Lamodal or Imodium. When I tell the patient, oh, you know what, take some more Lamodal, you'll be okay, the diarrhea will go away. You really have to document these changes, and you have to make the changes into the medication list. We all know the problems we're having currently with the newest version of CPRS, where they can't turn off a function that they found to be inaccurate, and they just send you a safety message every day saying, don't do it, don't do it. We have to try harder than ever to make sure that we have the documentation, including discontinuation, because that is one of our problems. So the chemotherapy, the oral chemotherapy falls under the outpatient package, and when patients are admitted, what happens? They just renew everything. Everything is brought over. So now so they're being admitted for progressive disease, and the medication that was discontinued is now being restarted in the inpatient. Now that's a VA unique perspective, but think also if you're not in the VA in the private sector, they also have problems that the patient is given a prescription with 10 refills, 6 refills, okay? Come back and see me in 6 months, 6 refills, 1 year, so they take it to the pharmacy. It's discontinued. Patient, for some reason, is unclear, or sometimes, you know what we've discovered? The patient actually wants to continue the medication. Sometimes the patient just doesn't believe you that it's progressive disease, or they haven't bought into it. So even in our setting, the patients, when we discontinue a drug, we try to make sure we get that drug back from the patient so they're not continuing to take it at home on their own. But in the community, if the patient has multiple refills on their prescription, it may be appropriate to have a process in place where you call the pharmacy and say, listen, that drug has been discontinued. Please do not continue to dispense it. The labeling requirements are such that what they want you to make sure that you do is that the duration of therapy is included on the label. Now, this is obviously very important if you're doing cyclical dosing, but it's also important if you're giving partial doses. So a cost-cutting measure that we've started to take is on assessment. If we feel the patient's not really fully engaged into the process, we may give them a partial dose so that we don't throw out 3 weeks of medication. But how does pharmacy or how does nursing know that we don't mean to give just, this is going to be cyclical, 1 week, come back in 1 month? How does the person who makes the follow-up appointment know? So if you're going to be giving a partial dose, what the recommendation is that you indicate on the label as such that this is a partial dose, that this is not meant to be 7 days every 4 weeks. This is meant to be a continuous treatment. The other thing that should be on there is the number of refills, including none. So sometimes, again, if we're concerned about patient engagement or patient response, is the patient really going to respond to this treatment, we may give a drug once, no refills. If there are no refills, then there should be none under refills or 0, so that the pharmacy realizes that it's not that refills were just inadvertently not ordered. Because remember, in every system, there are some processes that are already in place for managing no refills. If I walk into CVS, I can get my prescription refilled because they have a process in place. If it's ongoing and I routinely see my physician, they know they can call the office, speak to the nurse, and get a one-time renewal until I can get in there. So that's why there are processes in place to be able to handle no refills. So when we're giving oral chemotherapy, we need to make sure that we have processes in place that to make sure that it doesn't happen or happens in a way that we want it to happen. Okay, so although they dropped the concept of patient engagement, they did add a new standard in which the nurse or the provider needs to assess how much the patient seems willing to follow along with this process. Now, this is then going to be very patient-centered because this cannot be assessed by every patient in the same manner. But everybody is going to have to come up with a way that they incorporate into their documentation whether or not this patient seemed to really want to participate in this treatment plan and how is that going to be documented. The patient education material needs to be more detailed than it's ever been. It's not enough just to hand the patient the drug sheet anymore. We have to say, when do you take it? What time? What's the definition of an empty stomach? Can you don't split the drug? Can you split the drug? How do you handle disposal? And it all needs to be in writing. Just last week, before I went away to a conference, a local conference, we started a patient on Xelox. So capecitabine is an oral agent. And I thought, very invested patient, had a very supportive mother, and I thought we had gone over everything. We had gone over everything several times, multiple times, and I wasn't the only one speaking to them. When I got back on Monday, the mailbox was full of questions from his mother, because it turns out that to make it easier for him, she had been cutting the pills in half. Right. Even though the bottle was fully labeled, even though everybody had told her not to do it, she was cutting the pill in half to make it easier. Well, my first concern, it was only a couple of days, so I was going to give her a call, but my first concern was, why wasn't he swallowing the pill? What was the problem? This was new. And when I called the patient, oh, he had no trouble swallowing the pill. It was just that the pill looked big, and his mother wanted to make it easier for him to swallow because that's all she could do. So we had all missed an important component in terms of the education process, in that his mother was trying to take care of him in a way that we had not anticipated. Patient education needs to be extremely detailed. Included must be what to do if you have a side effect who to call if something goes wrong, and what to do with the medication if it's stopped. Then, of course, a verification of IV pump rates. That was something that should have been in there initially, and it was added. Then assessment of adherence is new. Okay, how are we going to assess whether or not the patient is taking the drug? So now we had an instance where a patient came in, provider had done a great job of documenting when the medication was ordered, when the patient told him that the pill was taken and started, and how long the pill was going to have to be taken. Unfortunately, once he got inpatient, the patient denied all of this. So what did we do? Pill count. You have to have a plan in place. How are you going to make sure that the patient is adhering? Then, of course, enhanced communication. We need to make sure that it's a two-way communication with our patient, with pharmacy, with outside providers, with the visiting nurse, with hospice nurses. There is more people involved in this than ever. So, what are the challenges? Because we went from 31 standards to 35 standards. We love nothing more than to set up standards for ourselves, things that we need to do. However, in 2012, a study was done by Dr. Weingart called the U.S. Cancer Center Implementation of the ASCO ONS Chemotherapy Administration Safety Standards. And these were the 2010 standards. A survey of the NCI designated cancer centers was performed, and 44 out of a possible 55 responded. They identified 99 different items in the 31 standards, because the standards do have different items in them. Only 4 centers, and these are NCI designated cancer centers, had been able to implement all the standards after 2 years. Why? Because they're very complex. Everyone has time restrictions, staffing restrictions. There is a lack of consensus over a lot of the standards. It's not evidence-based, it's expert-based. And there is often a lack of efficient tools to be able to allow facilities to implement that. So given that, the last thing I wanted to talk about, because I am an administrator as well, is how did this new standards impact upon the core competencies for nursing assessment in administering chemotherapy? Remember, standards are things that are nice to do, and as we see, even in 2010, they were not able to implement all the standards in cancer centers. Core competencies are things that 100% must be done. So what we have recommended is that there be outcome measures, that the nurse is able to identify the unique requirements for the care of patients receiving oral antineoplastic agents. And that means that he or she is able to assess the patient's understanding of disease, stage, health literacy, social support, degree of behavior changes required, and the treatment plan. Performs medication reconciliation accurately, educates the patient on missing doses and toxicities to report, performs physical and cognitive assessment. Please open this bottle for me in front of me. Can you please read the label, because the print is very small. Schedules ongoing assessment visits for planned repetitive follow-up, however it wants to do, and generates the ongoing treatment plan. It is up to nursing to generate that document that will allow all the disciplines to communicate. Anyone have any questions?